Thank you for joining us for the Johns Hopkins Government and Community Affairs Showcase Series, which highlights several initiatives at Johns Hopkins and their significance in the state. My name is Senator Melanie Griffith. I represent the District 25 in Prince George's County, and I'll moderate today's discussion. Today, we'll talk with Dr. Otis Brawley from Johns Hopkins Sidney Kimmel Cancer Center about his world-renowned research that has been made possible in large part with support from Maryland's Cigarette Restitution Fund. Dr. Brawley's research focuses on the development and evaluation of cancer screening techniques, which have changed patient care by improving quality of life and lowering health inequities. Throughout his career, Dr. Brawley has championed initiatives to reduce smoking and introduce other lifestyle risk reduction programs, as well as to give vital support to cancer patients and focus cancer control efforts where they'll be most beneficial. Brawley currently directs a comprehensive interdisciplinary research effort on cancer health disparities at the Bloomberg School of Public Health and the Johns Hopkins Kimmel Cancer Center, aiming to eliminate racial, economic, and social disparities in the prevention, detection, and treatment of cancer in the United States and internationally. He oversees community outreach activities in Maryland for marginalized groups. Now, before we get to the discussion, I'll go over some logistics. First, this webinar will be recorded and will be posted to the Hopkins at Home website with captions included. Additionally, the questions and answers function has been enabled during this webinar, so please feel free to type questions there. We will do our best to respond to as many questions as we can during the time that's available. And with that, I'll ask Dr. Brawley to tell us more about the Cigarette Restitution Fund. Dr. Brawley?
Senator Griffith, thank you so much for the introduction, and thank you for having me here today. What I'd like to talk about is a little bit about my work and a little how the Maryland Cigarette Restitution Fund is funding my work and work of other scientists to help improve the health of people in Maryland. In brief, I'm a medical oncologist and epidemiologist in the School of Public Health and the School of Medicine at Johns Hopkins. I study disparities in health and try to figure out how we can help those who need help in terms of getting medicine. The disparities in health is the concept that some populations don't do as well as others, and those populations can be defined by race, ethnicity, where people originated from, where they live, or socioeconomic status. The various measures of health disparities include cancer incidence, mortality, survival, as well as quality of life. And while I'm talking about cancer, I want to point out, we could also talk about diabetes or cardiovascular disease disparities, or even disparities in infectious disease, COVID or HIV, for example. Now, by studying these disparities, we can figure out interventions that help us to reduce these disparities. Just to show you a few numbers, and this goes to 2019 because it's the last year before COVID. Heart disease claimed almost 650,000 lives in the United States, cancer about 600,000, accidents in 2019, 169 to 170,000. Coronavirus in 2020 claimed 400,000 lives, at least in 2021, slightly more. Cardiovascular disease death rates have been declining over the last 30 years or so, and cancer is eventually going to become the leading cause of death in the United States. Right now, heart disease is number one, cancer is number two. Within the next 5 to 10 years, cancer will be the leading cause of death. Now, cancer is more than 200 diseases, and half of all cancer deaths are due to cancer of the lung, cancer of the colon and rectum, cancer of the breast, or cancer of the prostate. When we talk about cancer death rates per 100,000, in 1900, 64 Americans for every 100,000 Americans died from cancer. And it rose throughout the 20th century. In 1991, for every 100,000 Americans, 215 died from cancer. Thankfully, since 1991, there's been a 31% decline in the risk of death from cancer. It's now down to 149 per 100,000, but we'd love to get it back down to 64. And that's much of my work is designed at how can we get better? Where are the disparities? Well, one disparity is by race or ethnicity. Here you can see the decline from 1990 to 2017 for Blacks in blue, whites in orange. Native Americans are in gray here, and they have not had a decline at all, but they started out lower than whites. Hispanics are in yellow, and you can see there's a decline for Hispanics, and Asian Pacific Islanders are in dark blue. Again, Blacks in the United States have had the greatest decline in death rate since 1990. However, they started out with the highest death rate. Whites have had a decline, but their death rate is greater. Their disparity is greater than that of Native Americans, Asian Pacific Islanders, and Hispanics. Now, the declines that we've seen are because of a number of things: risk reduction or prevention activities, appropriate screening activities, appropriate diagnosis, and appropriate treatment. Some of what we do is document the fact that some populations do not get appropriate risk reduction or prevention, appropriate screening, appropriate diagnosis, or appropriate treatment. Indeed, how can we provide adequate high-quality care to include preventive services to all populations is an incredibly important question. And we need to realize that when we give unnecessary care, we interfere with our abilities to provide necessary care, and the provision of unnecessary care creates disparities. Now, let me talk about some emphasis here. First emphasis, adequate high-quality care. Some of our work has documented that there are Americans who get less than adequate high-quality care. Second thing, preventive services. So frequently people stress treatment or screening and treatment and don't stress prevention enough. So we want to stress adequate high-quality care to include prevention. And again, unnecessary care actually causes disparities. Now let's talk about breast cancer in the United States, and then we're going to pivot and talk very specific to Maryland. In 2020, there were about 269,000 women diagnosed with breast cancer, about 42,000 who died. There's been a 40% decline in risk of breast cancer death since about 1990. That's a really good thing. The average woman in the United States today, her risk of dying from breast cancer is 60% what it was for the average woman in 1990. By the way, a little less than half of this decline is due to very good screening and treatment. A little more than half is due to improvements in how we treat the disease. Now, just told you it's 40% decline in the United States as a whole. There's a very busy map of the United States. The purple states are where we've had a 20 to 29% decline, and the very dark blue states are where we had a 44 to 51% decline. You see, it's been 40% for the United States as a whole, but people in the Deep South have not enjoyed the declines as people in the Northeast have enjoyed. We have state-by-state disparities because we have state-by-state disparities in treatment, quality of screening, quality of prevention. Colorectal cancer. This is the numbers for colorectal cancer in 2020, about 145,000 diagnosed, about 51,000 dying. But there's been a halving of the risk of death from colorectal cancer since the early 1980s. About 2/3 of that decline is due to improvements in our ability to screen. Now, I just said a halving in the United States as a whole, but again, the purple states 12 to 31% decline. The dark blue states 55 to 63% decline. When I talk about disparities, one disparity is Mississippi and Massachusetts started out at the same death rates in 1980, but Mississippi has had a 12% decline and Massachusetts has now had a 63% decline. You know, when I started studying health disparities 30 years ago, it was always Black versus white. Then it started being rich versus poor. And now it's starting to be Mississippi versus Massachusetts. Now let's look at Maryland. Here are the 26 counties of Maryland and Baltimore City. I want to show you that in the very dark purple, Baltimore City, Dorchester, and Somerset counties, they have death rates from cancer that are greater than 25% above the US rate. In the purple counties here, Washington, Cecil, Calvert, Charles, St. Mary's, Wycomico, Queen Anne's, they are 10 to 25% above the national average. Interestingly, Montgomery County is greater than 25% below the national average death rate. Let's look at the counties a little bit better. These are all cancer, all types of cancer. You can see Baltimore City has a very high death rate, Montgomery County, very low. Indeed, the risk of dying from cancer in Baltimore among residents of Baltimore is more than 1.5 times the risk of dying of people in Montgomery County. You can see Maryland as an average, the United States as a country as a whole, and you can see the various counties that are above the Maryland average, the various counties that are below the Maryland average, the counties that are doing something good and the counties that we need to do something better. Now, I should point out to you, Maryland has improved dramatically over the last 30 years. It was 47th or 48th among all states for death rate from cancer. And now Maryland is about 25th or 26th. So it's gotten better, but we can get even better. And certain counties, we need to do much more. Let's look at lung cancer, a disease that we can do a lot more because we know the major cause is smoking. And you'll see in Montgomery County, the death rate is 20 per 100,000. In Somerset County, the death rate is over 60. People in Somerset County are 3 times more likely to die from lung cancer than people in Montgomery County. People in Somerset and Cecil counties are twice as likely to die from lung cancer as the average Marylander. Colorectal cancer. Again, colorectal cancer has had a 50% decline over the last 40 years due to screening. And you can see dramatic variation. Many counties here at 10 per 100,000, Wycomico at nearly 20 per 100,000. Breast cancer. You can see the national average here at about 20 deaths per 100,000, but in Prince George's County, it's at 25. At Talbot and Allegheny, it's at about 15. This is evidence that we can do something to improve the death rate in these counties that have very high death rates from breast cancer. Here we have prostate cancer. Again, the death rates vary by a factor of 2 between Montgomery County and Baltimore City. How can we provide adequate high quality care to include preventive services is an incredibly important question. Now, when we talk about preventive services, these are the causes of cancer. 42% of all cancers, we know the cause. 19 to 20% of all cancers are due to smoking. About 15% are due to bad diet, obesity, and lack of exercise. It's a three-legged stool. Too many calories, not enough exercise, and storing those calories, obesity. Alcohol, 5 to 6% of all cancers are due to alcohol consumption. Ionizing and UV radiation, to include medical diagnostic radiation and sunlight, causes almost 5% of all cancers. Indeed, one of the reasons why I preach we need to be careful and cautious and do screening that's important, not screening that's unimportant, is almost 5% of all cancers are due to radiation. And infections such as hepatitis, HIV, or human papillomavirus in the United States causes about 3% of all cancers. And here you can see the numbers of cancers in the United States. There are about 1.4 million cancers diagnosed in the United States every year. 42% we can identify the causes. Tobacco addiction or use of tobacco causes a lot of cancers, but it's declining over time. These are the major cancers caused by tobacco. Everybody knows about lung and throat and mouth and esophagus. Many people don't realize kidney and bladder, liver, stomach, even acute myeloid leukemia is linked to smoking. Now, we've come a long way in terms of smoking. In 1955, 55% of American men smoked. In 1965, 35% of American women smoked. And it's gone down dramatically since the Surgeon General's report in 1964. Among races and ethnicities, among genders, you can see it's about 16% or so of Americans smoke today, but it varies dramatically by race and ethnicity. It varies dramatically by education. 4% of people with a graduate degree, 18 to 20% among high school dropouts. And yes, people who have a GED, part of that drive to get a GED is also leads them to smoke more often. When we look geographically throughout Maryland, here's the United States average for smoking, Maryland below average, but look at Western Maryland. Look at Central Maryland does fairly well, but Baltimore City within Central Maryland is high. The Eastern Shore. One of the themes of my talk is we have to worry about cancer control, prevention, diagnosis, and treatment in the far east and far west of Maryland and in Central Maryland and Baltimore City. Here's the Eastern Shore. Compared to Maryland as a whole, the Eastern Shore, 19.7% are smoking. Southern Maryland, and then the National Cancer Capital Region, Prince George's and Montgomery County, very low smoking rates. Again, the causes of cancer. Now, when we talk about energy imbalance, that's eating too many calories, not exercising enough, and obesity. Three-legged stool. It's not just obesity. These are the cancers that are related to energy imbalance. And in Maryland, we have food deserts where people cannot buy things like fruits and vegetables. We also have food swamps where people can buy lots of calorie-dense, bad food, especially fast food. And this leads to the obesity epidemic. Here's some other diseases, cancers that may be associated with the obesity epidemic and energy imbalance, especially aggressive types of prostate cancer and male breast cancer. Just to compare the United States to the world, this is obesity starting in 1970 in the United States. 15% of adults were obese. Today, it's well over 40%, and it's growing toward 45% compared with other countries. This obesity thing is a problem in every country, but it's a worse problem in the United States. And for certain groups, it's even worse. Look, 57% of Black women are obese compared to 40% of white women. The obesity problem for Black women has grown over the last 30 years. This is looking at Asians as well. It's not a problem for Asians as it is for whites, as it is for blacks, as it is, I'm sorry, whites in blue, blacks in orange, Hispanics in yellow. And this shows you it's a problem for men as well as women. Again, I mentioned earlier, energy imbalance is going to be the leading cause of cancer in the United States within the next 5 to 10 years. It already is for Black women, especially Black women in Maryland. Again, I leave you with the causes of cancer. Now, the control of most chronic diseases, not just cancer, but cardiovascular disease, diabetes, even orthopedic injury, is through risk reduction. It's the most effective way to do it. This involves a healthy lifestyle with exercise and calorie management, a balanced diet rich in plant sources, management of carcinogen exposure, be it tobacco, sunlight, pollution, and alcohol. And I'm going to end just with a word about cancer screening. Cancer screening is incredibly important, but we must be cautious. In the United States, there's a lot of unwise cancer screening that causes health disparities. You see, when we do cancer screening, we need to optimize the benefits and minimize the harms, because there are harms. We know that mammography for women over 45 benefits those women. We know that colon cancer screening, especially stool blood testing, ironically, benefits people. Colonoscopy and stool DNA, we do believe benefit, but ironically, the data is not as strong as in stool blood testing. Pap smears for cervical cancer screening. And for those at high risk because of smoking in the past, and hopefully they've stopped smoking, spiral CT screening for lung cancer. Okay, these are the things people ought to be getting, and it's very important that they be in a well-structured program of routine screening. Okay, too frequently, the message is get a mammogram. The message needs to be get into a program of routine, regular, high-quality mammography. Emphasis again on routine, regular, and high quality, because we've got data to show that there are some people, especially poorer people, who get low quality screening. And low quality screening is as worthless as no screening at all. And too often the screening is one off. Again, how can we provide adequate high quality care to populations that so often don't get them? I spend a lot of time figuring out who those populations are, where they are, and figuring out interventions to help us provide these folks with better high quality care. And I leave with a picture of the old Johns Hopkins Hospital, built in the 1880s, still in downtown Baltimore. Thank you very much, and I'm more than happy to take questions.
Thank you so much. I'm sure the people that are watching, like I have been, learned some things from your presentation. I hadn't heard about the 200 diseases. That was something that jumped out at me when you said cancer's like 200 diseases. I also appreciated your pointing out sunlight as one of the contributors. So we do have some questions that we're going to raise, Dr. Brawley, if you have time.
Sure.
And the first one is, can you share with us what has been the impact of your research in Maryland?
Well, I would hope that my research has helped to help people understand what the problems are and where the focus should be. I will say, I will hope that's the impact of my research. I can tell you the impact of a number of investigators who have been funded by the Cigarette Restitution Fund over the last more than 20 years is Maryland used to be one of the worst states for cancer death rate. And now it's in the middle of the pack, and it's one of the states that's been moving lower and lower over the last 20 years or so. And I would relate that not to my work and my funding from the Cigarette Restitution Fund, which has only been happening for 4 or 5 years. I would link that to my colleagues who have gotten money from the Cigarette Restitution Fund.
Now, that's very helpful. And it would also interested to know, you kind of talked about the impact of your research thus far with funding from the Cigarette Restitution Fund. Can you tell us what future research you hope to complete with that funding?
We are working hard to develop interventions that can lower the death rate from cancer. Interesting questions. How do you convince children and their parents that they need more fruits and vegetables in their diet? How do you convince children and their parents to avoid some of the high-calorie foods? How do we increase the amount of exercise? By the way, I focus so much on children because cancer prevention is a pediatric issue. If a child gains a great deal of weight from birth to the age of 15, that girl, when she's in her 50s and 60s, is at a higher rate of not just breast cancer, but the more aggressive types of breast cancer. So I can ward off or decrease her risk of those aggressive breast cancers by working on her diet when she's 5 and 6 years old. It's astounding. You can do something now to prevent something 50 years from now. But those are the sorts of things that we're working on. How do you educate parents as to what they should be buying for their children? How do you encourage women who have just had a child to breastfeed? Because it's going to actually decrease that woman's risk of breast cancer 20 to 30 years later. A lot of what we're into is health education.
Very important questions that you and your colleagues are asking. Certainly, one of the questions that we would like to hear from you, Dr. Brawley, what state policies and resources have made your research, or really any medical research, more successful?
Well, I think the greatest thing that the state of Maryland has done is tax cigarettes. We have good data to show that excise taxes on cigarettes decrease the number of people who buy them, especially decrease the number of children who buy them. By the way, the average age that a Marylander starts smoking is 15. All right. And so if you raise the price of a pack of cigarettes by just 50 cents, you make it more expensive for these 15 and 16-year-olds to buy it. And guess what? They don't buy cigarettes. So the absolute most important thing that the state legislature in terms of laws have done is taxing cigarettes, making it harder and harder for people to smoke cigarettes through clean air laws has also been very important. Clean air laws also prevent people from getting secondhand smoke. By the way, we have data to show that crib death is linked to secondhand smoke. So it's not just preventing people from having cancer. I should also note cardiovascular disease is more linked to cigarette smoking than cancer. More people die from cardiovascular disease because of cigarette smoking than die from cancer because of cigarette smoking. And as I noted with secondhand smoke, or we sometimes refer to it as environmental tobacco smoke, it's not just the smokers who suffer.
Thank you for that. Boy, there are a lot of things that you have to keep your eyes on and keep focused on. And I think you probably answered this a little bit in your last response. You were kind of sharing how state policies have impacted your work and other medical research. But are there any policies that the state should be looking at that are needed to further enhance your research?
Oh, thank you for asking that question. We really need to look into our curriculums in schools. We need to teach health. We need to promote health. Too often, when you're in 2nd and 3rd grade, health education is this is how you play baseball, or this is how you play soccer or football. We need to impart on children the importance of aerobics, the importance of being able to exercise and have endurance. We need to teach them the importance of a balanced diet, the importance of weight control. These are things that we need to get into our curriculums in grade school. We also need to, of course, get them into our PTAs and get them to the parents who are overseeing these kids. Programs like that. You know, I've often, Julius Richmond started Head Start back in the 1960s. And Head Start was an incredibly successful program. I wish we could bring back these ideas of getting young kids when they're 2, 3, 4 years old, more education, get them grounded in the basics so that they can learn more. And by the way, children who went through Head Start in the 1960s have a lower cancer rate in the 2020s compared to children who did not.
That's interesting. Interesting. That's where research kind of informs what we need to do next. So thank you. Thank you for that important information. We have a couple of questions that have been raised. The first two that I see are related to COVID. The question is, how did COVID impact the distribution of health disparities?
Yeah.
And do you believe people are going to the doctor more or less now?
I believe people are going to the doctor less. Keep in mind, I'm heavily into not just make sure that we screen people, make a diagnosis and treat them, but get them on a pathway in terms of health behaviors such that they don't get sick to begin with. In the United States, we stress diagnosing and treating. We don't stress enough impart behaviors on people so that they don't get sick. COVID overwhelmed our hospitals. It pushed people who, I take care of cancer patients who I would have hospitalized, we kept out of the hospital and kept at home because they were better off at home versus in an overrun hospital where they might catch COVID, or in an overrun hospital where the nurses and doctors did not have time to take care of them because they weren't as sick as the people with COVID. COVID was devastating. COVID prevented a lot of good treatment. COVID prevented some screening that we wished had occurred. COVID has been a real problem. At the same time, there are some benefits from COVID that people are actually starting to think about health in ways that they never thought about health before.
Excellent, excellent. And in that answer, you kind of answered the second part of that question, was asked how has COVID impacted preventative care? And you kind of talked about that, people sort of underutilizing the in-person visits that might have been taking place pre-COVID, and the new problems it's created and what people are doing to work around those problems.
Yeah, speaking of new problems, you know, we've started having some polio showing up in the population, especially just outside New York, that has a very low vaccination rate to begin with. There are a large number of children who should have gotten vaccination last year and this year and the year before who did not go to the pediatrician and get measles, mumps, rubella, polio vaccine. And I worry about those folks. I worry not just about polio, but measles is the other one that we can easily lose control of and start having an epidemic or pandemic because of failure of folks to get vaccinated.
Right, thank you for that. So the next question that we have, and this may be tough for you to answer, I don't know how much interaction you've had directly with legislators, but the question is, what facts about cancer research do our legislative bodies not understand that they should know?
Well, you know, in my previous job, I was chief medical officer of the American Cancer Society. So I got to meet some legislators, not just in Maryland, but a number of states, a number of governors, and some national legislators. It's this is a problem even for many doctors. They think that the cancer problem is easier and simpler than it actually is. One question I see coming up, how can screening negatively affect people? There's a lot of people, and politicians are people, who think every screening test must be good. Now, screening tests are, the purpose of a screening test is not just to find the cancer, it's to find the cancer and prevent the person from dying. They're two separate things here. You know, in prostate cancer in the 1990s, we were screening like crazy for prostate cancer. And then we found out that about half to 50 to 60% of the men who we found with early stage prostate cancer, who we treated with a treatment that caused urinary incontinence and impotence and sometimes death, 50 to 60% of them, if we did nothing, they lived long, healthy lives and died of something totally unrelated to prostate cancer. Okay. Now, prostate cancer screening can be a good thing, and it does find some men who need to be cured. But it took us a long while to figure out we needed not just a test to find the cancer, we needed a test to find the cancers that needed to be cured and the cancers that didn't need to be cured. And we could spare the men who didn't need to be cured of all the problems of prostate cancer treatment. And that's how screening can be a negative, when it is done in an unwise way. Even when done in a wise way, it can be harsh. Lung cancer screening, which is now commonly done for people who have a long history of smoking, the studies that tell us it saves lives tell us for every 5.4 lives that it saves, it causes surgeries that kill one person. Yes, it saves lives, 5.4 lives saved for every one life lost. And that's one of the reasons why Medicare will not pay for lung cancer screening unless a person to be screened is informed of the potential risks and the potential benefits and says, yes, I want lung cancer screening. And my advice to that person considering lung cancer screening is go get it from a good place.
Yes, you've pointed out high quality screening several times. That'll be definitely one of the takeaways from today. If you can talk a little bit about what challenges, and you did in your presentation a little bit, talk about the challenges that Maryland in particular faces when it comes to reducing cancer disparity rates, which seems to be a national issue, but this question is Maryland specific.
Yeah, well, I think Maryland can set a standard in the United States because, as I noted earlier, the US is very much into screen, diagnose, and treat. We are much less into the long-term investment to prevent disease. I think if Maryland can get into that long-term investment, which is cheaper, by the way, than screening and treating, we can set a standard and be an example for other places. You know, and that investment involves, and there's some wonderful things, by the way, in state of Maryland government. I've talked to folks from the Maryland Department of Agriculture. They're interested in how can we promote increased growth of fruits and vegetables and increased consumption of fruits and vegetables. That's the kind of thing that can help us economically and help us in terms of our workforce being healthier. The promotion of health in the state of Maryland is something I think we can do very well. You know, we've got Appalachian regions in Maryland, we've got fishing regions and agricultural regions. You know, we're sort of a microcosm of the entire United States, and we can teach folks in the United States how to do it right.
Excellent, excellent. Let us be the first to get it right. Thank you for that. And I noted your comments about prevention in addition to screening, diagnosis, and treatment. That's something we need to reinforce. Someone is interested in learning how anyone can support the work that is currently being supported by the Cigarette Restitution Fund. How can somebody support this important research and work that you're doing?
Well, we are very interested in talking to the community and getting words of wisdom from the community. I have, in my 30-year career, come up with interventions that I thought would be great in a community. And folks from the community looked at what I was going to do and they said, you just don't understand. Mm-hmm. So I'm really into bidirectional discussion. Let me teach you a little about the science and you teach me a little about how we can apply some of that science when it comes to prevention and risk reduction. So we're very open. We have community advisory boards and community advisory groups where we want to meet with folks and talk. Now, the person said, how can you support research? If you want to write us a check, please. But another way that you can support us is get involved in our community advisory groups, and it's accessible through the Kimmel Cancer Center website, or they can send us an email and get involved. Tell us what we need to do, understand what we're trying to do, help us make our science better, and help us make our science more tailored to the needs of the community.
Thank you. Thank you. Noted. Checks are welcome. We caught that. Okay. We do have a question. Do you anticipate, should people look forward to some new treatments like cancer vaccines that might help reduce the disparities? And what developments are you most excited about as you look forward?
That person knows exactly what excites me.
Okay.
Richard Nixon declared war on cancer a little over 50 years ago. And I'm going to make a non-political statement that sounds like a political statement. What we got from Richard Nixon, that Republican president, was a number of amazing things. By the way, the messenger RNA vaccine for COVID is directly linked to Nixon's war on cancer, started in December 1971. The basic science that helped us to understand what cancer was, helped us to understand what's going on in science, inside the cancer cell. All that basic science was applied to make the messenger RNA vaccine. By the way, keep in mind, Moderna, one of the major vaccine manufacturers, it started its life as a cancer vaccine company about 10 years ago. We have made tremendous strides over the last 50 years in understanding what cancer is, what's going on inside the cancer cell, being able to predict the cancers that kill and need to be treated, and the cancers that don't kill and don't need to be treated. Those are all things that we've gotten over the last few years. Now, in terms of treatment, we have, for years, treatment was just surgery, then it was surgery and radiation, then it was surgery and radiation and chemotherapy. For certain diseases now, not all cancers, certain diseases, we have been able to harvest the immune system and actually train the person's immune system to attack their cancer. We do that very well with some lung cancers, some bladder cancers, not as well with breast or prostate or colon cancer yet, but we're getting there. So our treatments are improving. I'm very excited about some of the immunotherapies that we have that just in the last 10 to 15 years, they didn't exist more than 15 years ago. Just in the last 10 years, we've noticed that our ability to treat lung cancer with chemotherapy or immunotherapy is actually saving lives. It used to be we would give them the chemotherapy to try and make them live longer. Now we're giving them the chemotherapy such that they cancer, we don't really cure many of these cancers, but what we do is we convert these cancers into something that people peacefully live with, sort of the diabetes model. You know, we don't cure people with diabetes, but we fix it so that they can live and function with their diabetes. Well, we're starting to do that with certain cancers. And that's one of the most exciting things in the last 10 years or so. But it was that investment in research that started in 1971 that started paying off in 2015 and 2020. It's a long-term investment. The Cigarette Restitution Fund is a long-term investment to try to help us even more.
Wow, fantastic. Well, thank you so much, Dr. Brawley, for your time and all your work to help address health disparities through this critically important research. Now, as a member of the General Assembly and as a Marylander, I think it's critical to have research like this in our state. And I really look forward to continuing to support your work and to hear about the impact of the work that you're doing with the cigarette restitution funding.
Well, I just want to say thanks to you.
Oh,
because without work from state senators and state representatives like you, I can't do my work. I'm dependent upon you and the work that you do. And I really, truly appreciate, number one, your interest in my science. I should say even more than number one, your interest in my science, your interest in our people and keeping them healthy.
wow, thank you so much. And I do appreciate your remarks, and I also want to thank those who tuned in to listen to the conversation in this showcase series. Johns Hopkins Government and Community Affairs team will host more of these events in the future, highlighting the anchor institution's relationship to Maryland. And for questions, viewers can email gca@jhu.edu. Thank you so very much for a valuable exchange.
Thank you.